Good morning and welcome to FHCA's webinar series on the patient-driven payment model. I'm Melanie Motiska, Quality Improvement and Education Manager for Florida Healthcare Association. Before we begin, we'd like to thank our supporting sponsor, MedPass, for their support and sponsorship. MedPass is a provider of long-term care documentation, e-solutions, reference tools, policy and procedures, and your source for MDS resources. Please take a moment after this webinar to visit their website to learn how MedPass can prepare you for PDPM. Thank you, MedPass, for sponsoring today's program. Let's get some housekeeping notes out of the way so we can get started with today's great program. Due to the large number of participants, all attendees are muted, and we encourage you to use the computer audio rather than a telephone to maintain sound quality for today's presentation. A copy of the presentation is available under the Handout tab on your control panel. We encourage you to ask questions throughout the presentation by typing your questions into the question box on the control panel. You may also email me directly with your questions at mmotiska@fhca.org. We will compile a Q&A document and make it available through FHCA's various communication channels. This webinar is being recorded, and an online archive will be available in the members-only section of the FHCA website. If you have a colleague unable to join us today, please encourage them to view the recorded webinar. I would now like to introduce today's speaker. Dr. Kathleen Weissberg, in her 25 years plus of practice, has worked in long-term care as a researcher, educator, and established various programs in nursing centers, including palliative care, incontinence management, falls management, regulatory and reimbursement, dementia care, and staging. She provides continuing education support to 6,000 therapists nationwide as Director of Education for Select Rehabilitation. She has developed several CE activities for nurses on this topic and has lectured on this topic for the American College of Healthcare Administrators, TN, NHA meetings, and several other state association meetings. With that, I'd like to turn the program over to our presenter, Dr. Kathleen Weissberg of Select Rehabilitation.
Thank you for that introduction, Melanie, and thank you for everyone for joining in today. So I'm going to pull up my slides for you. And we're going to go ahead and get started. And thank you, too, to the sponsor for today's session. It's interesting that our sponsor is related to MDS coding, because that's a lot of what we're going to be talking about today. So with that, let's just jump right in. And I like to start on this slide. Sir Isaac Newton said, for every action, there is an equal and opposite reaction. And that's really what we're going to be talking about today, is a strong focus on MDS coding and how that coding impacts PDPM reimbursement, the PDPM rates. And just as by way of background, Select Rehabilitation, so the company that I work for, we have been auditing, and honestly auditing about easily 15,000 or more patient records from clients across the country. And what we're finding in those audits, and this is what's interesting, is that the MDS does not always reflect the medical record and does not always reflect the patient. So there's stuff in the medical record, in the documentation, that we're not coding on the MDS. And if we were to fast forward and use those same MDSs for PDPM, there would be a pretty significant impact. So the biggest issues that we're seeing and that we're going to hit on today are the BIMs, the brief interview for mental status, section C of the MDS. I mean, we're seeing examples where, patients scored a 15 on the BIMs and they have Alzheimer's or dementia, which we know is not congruent. Or the PHQ-9, another one, our section D, where we look for mood and signs or symptoms of depression. Again, somebody scores 15, they spend most of the day sleeping in bed and are known to have depression. So GG is the other one. So those are some of the big ones that we're going to be hitting on today. And again, the MDS right now may not be a true reflection of who your patients are that you're serving. So that's really what we want to talk about, is what are our practices surrounding that. So the objectives for today's session are listed on this slide. They are to describe key factors that will drive reimbursement under PDPM, illustrate how these variables will affect payment at a facility or a provider level, and then list some key facility practices that we'll need to consider for redesign under PDPM. So I do have a few review slides in here, and I'm certain that many of you are very familiar with PDPM already, but just so we're all on a level playing field, I want to do a quick review. First of all, recognize that PDPM is not a change of benefits, and we're hearing that throughout the provider community that, it's a change in revenue delivery system. Our patients should not be receiving anything less in October than they would be receiving now. And we're hearing some of that for people saying, oh, well, we're not going to be able to provide the care that we've always provided. And again, CMS has said the same thing. If you're not providing it now, you wouldn't begin providing it in October, and vice versa. If you're providing it now, the expectation is that you would provide it then. Obviously, this is a shift from volume to a patient characteristic model. And I'm a therapist by background, but I realize too that therapy has really run RUG system for how long, really, for gathering their minutes and getting those higher RUG categories. And I think the system makes a lot of sense where we look at truly what does the patient need, and where do they fall clinically, and that's obviously how reimbursement would fall out. We also know that the PDPM ideally, theoretically, would establish a rate on the 5-day MDS for the entire stay. And we'll talk about each of those components in just a little more detail with some examples. Again, theoretically, unless of course there's an interim payment assessment that would change that person's characteristics, or perhaps they had an interrupted stay or something like that that would change that payment. The final thing I just want to hit on, and we'll talk about this again, is that there's no change to Medicare eligibility for skilled care. And CMS has been really clear on that as well, that you still have your 7 days of nursing, your 5 days of therapy, medical necessity, documentation needs to show skill, all of those things. None of that is changing. None of that is going away. And I think sometimes those are some things that we tend to forget, and we'll talk more about that when we talk a little bit about documentation coming up. So you've probably seen this slide, or some sort of slide like this at some point. This talks about the different rate components. Obviously, there are 6 distinct rate components. 5 of those are variable. And again, we'll look at those in just a little more detail with some examples. So when you look at those components, these are the things that make up those components. And again, you'll see the clinical categories that is derived directly from Section J, Section I of the MDS. So your diagnoses codes and or your surgeries that a patient may have had. Your functional score for PT, OT, for nursing all comes from Section GG, not Section G. For speech therapy, that's coming from Section K of your MDS, and some other areas as well. Your BIMs would fall in there for speech therapy. Your NTAs are coming from a whole host of areas, some of those being in Section O, some of those in Section I, some in Section K, some in Section M, which relates to skin and wounds. So again, the MDS is driving everything. So no more will there be minutes or categories, those sorts of things. It's all based on the MDS. So if we're not coding it as accurately as we can, we may not get the reimbursement that we are actually entitled to for the care that we're providing to our patients. So I put this slide in here just for your reference, because we're going to be talking about this as we go through. These are actually the rates from the proposed rule that came out. They're not the current rates, but these are fiscal year 2020 PDPM unadjusted federal rates. The top part is urban, the bottom part is rural. And as we go through some of the case examples, we're going to get a case mix index, and that case mix index obviously is multiplied by this rate component to get that per diem amount for that specific component. So obviously all of these things, with the exception of the non-case mix, will have a case mix index that's multiplied out. There's that the variable case mix index that we'll be talking about in just a little bit. So I just put these here again for your reference. So again, just by way of review, let's start talking with the PT and the OT components. So PT and OT, there are 16 case mix groups. There is a variable per diem adjustment factor, and what CMS found with PT and OT is that there were factors that were predictive of the PT and OT costs, and they were the same factors. They are the clinical reason for the SNF stay. So that's the medical diagnosis that that patient has that then crosswalks to a category, and then the resident's functional status from section GG. They originally, and if you think all the way back, cognition was a factor here, and as the proposed rule and the final rule finally came out, they took cognition out. So cognition is a factor for speech language pathology, but not a factor for PT and OT. So this slide shows the PT and OT component for function, and we'll talk about this in an example here in just a moment, but you can see that there are 10 different items that are pulled together. The score anywhere between 0 and 24 for a patient to score here. Eating, oral hygiene, toileting hygiene are all standalone items. You have your bed mobility items that are averaged, your transfer items that are averaged, and then your walking items that are averaged. When we get to the nursing section, you'll see that those walking items fall off, and some of the same areas are scored as well. So this slide, again, just an overview, shows you the case mix classification groups. And again, I'm not going to go through it in great detail, but recognize on that far left column, the clinical category, this is the diagnosis directly from section I, and it will categorize into a major joint, other orthopedic, medical management, or a non-orthopedic. You then factor in the function score, and then you get your case mix group. Case mix groups for PT and OT are exactly the same. The thing that is different is the CMI. So you'll see in some cases, so for example, a non-orthopedic acute neurologic, the CMI for PT and OT is exactly the same. If you look at the very top one here, major joint or spinal surgery, you see that the PT component is a little bit higher than the OT CMI, and that's again based on the resources that a patient would need for that particular diagnosis, and typically they would require more physical therapy services. So before we go into examples, last thing we want to talk about is the variable CMI, and this is that adjustment factor. So for PT and OT, it's a 1.0 adjustment factor for days 1 through 20, and then PT and OT would decline every 7 days after day 20. And we'll probably talk about this on another slide, but one of the things that we are hearing again in the provider community is that, oh, we need to get everybody out by day 20. Our length of stay has to be shorter than 20 days. And it's an interesting thing if you've not done the math. Obviously, payment is going to decline starting on day 20, but if you look at days 20 through 27, the decline in payment is mere dollars, $2, $3 a day, if that, compared to what you might be getting per day for each of those categories if you kept that person in your community, again, if it's clinically appropriate to do so. A per diem amount, for PT and OT could be $55, $60 per day. So if we're thinking we have to get them out before this adjustment factor kicks in, I think we need to look at the finances of that. Of course, clinically appropriate will always come first, providing that the patient still needs to have care. But just to think that we always have to get everybody out early doesn't necessarily make sense. Now, speech therapy does not have a variable case mix index assigned to it, so only PT and OT. And then we obviously know too for the NTA, that's a 3.0 adjustment factor for days 1 through 3, and then that changes to 1.0 beginning day 4 of the stay. And we'll talk more about that when we talk about medical records and what we're getting from the hospital and how we're coding that. So, and this is just a screenshot of what that adjustment factor looked like. So with that, before I go into the next slide, Melanie, if you wouldn't mind launching poll number 1 for me, please.
Absolutely. Here's the first poll for today. Please give your response, and we'll share the results with you in just a moment.
So the question is asking, who currently is completing section GG of your MDS in your community?
Thank you so much for sharing your responses. I'm going to go ahead and close this out. And here are the results.
Okay, interesting results. So 13% of you say that nursing is completing section GG. 43% therapy, 20% the MDS coordinator, and 20% MDS, and 23% collaborating a team. So thank you very much for sharing that. That's kind of all over the boards. That's interesting feedback. So we're going to talk about that a little bit. It's a good question. Who is actually completing this now? And, CMS has said, again, they expect this to be a collaborative approach. It needs to be an interdisciplinary approach. So I think this is going to be a learning curve for a lot of us because it's very different from Section G. So if you're familiar with Section G and coding that, you have your rule of 3, you have, your assistance for the patient that if they required assist of 2, even once, you score it differently. Section GG is very much more in line with what therapy is probably scoring. And again, just a learning curve, I think, for folks who are going to be scoring this. The other thing with Section GG, just to keep in mind, that it is usual and customary performance. It is their baseline, it's their usual performance. We can assess that data from observation. We can get that from the medical record. We can get that from an interview with the patient, an interview with a caregiver. There's a lot of different ways we can get that. Again, what you want to make sure is that it truly is usual and customary. If therapy is scoring that, and oftentimes therapy does, are they skewing your data by coding it up? A lot of times the patient will perform a little bit better in therapy than they do in nursing or for someone else. So are they skewing your data? Would nursing be skewing it downward? I don't know. Does the MDS coordinator truly have the insight, and do they know the patient? Are they observing the patient? So I don't know all of those answers, but I do say this much. If it is therapy that is scoring this section, and we're going to go into an example here in just a second, but we are hearing if you're interfacing that data. So what I mean is if therapy is using some sort of electronic medical record, whatever that product may be, oftentimes there's an interface directly from that product over to your MDS or over to your medical record. We are already hearing that those interfaces for October may not be ready. So if that's your usual and customary way of getting that information from therapy or from someone else, please meet with your software vendors, make sure that they're on top of that. We'll talk about this at Medicare meeting when we get to the end, but that might be a conversation that you need to have as a group. The other thing that we are strongly suggesting as an organization is that include therapy in some of these other sections. So in Section B, in Section K for the nutritional approaches, Section D, your mood section, the BIM, Section C, the patients are spending some good quality time with therapy, and those are areas that a registered therapist can certainly assess and can certainly help to contribute some data back to your MDS. Again, not saying that they're going to take over scoring, that's not it, but again, to have a collaborative approach and make sure that we're hitting all of the areas for our patients. So with that, Melanie, if you don't mind going back into, yep, perfect, thank you. So let's look at an example of Section GG, and I think this is kind of where it hits home. So in this example, we have a patient who's in the medical management group, and in the initial evaluation, this person scored anywhere between 6 and 9 on their Section GG. So their initial scoring, eating they scored as supervision, oral hygiene, bed mobility as moderate assist, toileting and transfers as max assist, and we said that for walking, they either refused or they were not able to do that. So again, that puts that person into a medical management group, TJ, 6 through 9 on their GG. You can see the PT case mix index is 1.42, OT is 1.44. You multiply that out by the per diem amount, and I will tell you that these are the older per diem amounts. These are not from the proposed rule. And you get a composite, a subtotal for one day. This doesn't include, obviously, the variable case mix adjustment. $84 and change for PT, $79 and change for OT. Okay, so what if, however, you didn't really score that GG correctly? So what if for eating, it wasn't really supervision, but it was more setup assistance? We had a situation where if we really allowed the person extra time to complete the tasks and we set it up appropriately, the person would be able to do that. And I think that's a real scenario in a lot of our communities where we're shifting between multiple residents. We have a lot of things that need to get done. Maybe we don't set up the dining experience appropriately, or maybe we don't set up the oral hygiene appropriately, that the person could be more independent. So just that one change from supervision to set up assistance with eating bumps that person up into a TK group as opposed to a TJ. So that is 10 to 23 on their GG, and you can see the impact. So for PT, we went from 1.42 to 1.52. That's pretty significant. And for OT, 1.44 to 1.54. So again, the difference here was $84, now it's $90, so that's $6 per day, which again is pretty significant. And for OT, we went from 79 and change to 85 and change, which is again $6. So you can see just one small point of GG could make a huge impact. Now let's say it's not the eating. What if it, remember in the initial example, the patient either refused or was not able to walk? Maybe that's really not the case. Maybe therapy didn't assess walking. They didn't have time to assess walking, or they, didn't see it initially and they didn't interview the patient or get it from some other source, but the person could actually walk. That's one point right there. And again, that could bring you from 10 to 23, from 6 to 9 up to 10 to 23. So easy examples, and we're just doing this component by component. We're gonna have some big case examples coming up, but you can see the impact there of accurate scoring. So the message is, again, be collaborative, but more importantly, make sure we're assessing everything. I think sometimes we don't always do that. So let's go through a quick overview of the speech component. Again, 12 case mix groups. You already know that. No variable per diem adjustment factors. What CMS found was that the factors that were predictive of speech costs were the reason for the SNF stay, which is again derived directly from Section J, the diagnosis for the patient, the presence of a swallowing disorder or a mechanically altered diet, and or the presence of a speech-related comorbidity or cognitive impairment. And what they found, they combined a bunch of these. So they combined clinical category, cognitive impairment, and presence of a comorbidity into one predictive factor, and the swallowing disorder, mechanically altered diet in another. They found that the cost significantly increased when one of those was present, even more so when both were present. So I do want to take a second and talk about cognition, because we're going to look at some examples as it relates to the BIM. So we have the BIMs, we have the CPS score. So obviously, if the person can participate in an interview, we want to try to do the BIMs. And if they can't, we need to do a good staff assessment of their cognitive level. Some of the things that, again, through the chart reviews that we've been seeing, and also from what CMS has said, if you look at CMS's statistics, they're indicating to us that at a minimum, there are 15% of patients who are not getting their BIMS interview, and of those 15%, 12% of them probably could have participated. So there are cases where we're not doing the interview, and there are other cases. I just happened to see this in a community a couple weeks ago, where I was doing some training, and we know that the category cues and the instructions for the BIMs are very specific. They're standardized. So it's sock blue bed. And then there are very specific category cues that go with that. And this person was giving different category cues. So it has to be a standardized approach. We have to know what's in the RAI, and we have to follow that. And I think because we've done this for so long now, we tend to not necessarily follow it in such a structured way. So that's certainly a learning experience for all of us, that we need to make sure that we're doing that. So this shows the case mix groups. Again, I'm not going to go through this. You can see on the far left, it's none, 1, 2, or 3. Those are the conditions. The mechanically altered diet or disorder for swallowing, neither, either, or both. And then there's your case mix group. And again, that's multiplied by the speech dollar amount to get that daily per diem. And again, you can see the CMI here. If they have all 3 of those situations and both a mechanically altered diet and a swallowing disorder, their CMI is bumped up to 4.19. That's pretty significant. So when a patient does in fact need speech language pathology services, the reimbursement is definitely there for it. Now, one of the other things that we're hearing in the provider community is that, we're going to get paid for these rates no matter what. And we'll talk about this, I think, on another slide. And some individuals or some communities are saying, oh, well, maybe we won't provide that service. If we're going to get paid for it anyway, maybe we won't provide it. Maybe restorative can pick that up. And that's not necessarily the way to go. And we'll talk about why that is on another slide. So let's do an example here, and let's look at the BIM. So before I go into this, I just want to back up and say, if you've not read through your RAI manual, it's something we want to do. There's some really, really great information in there with regard to the interviews, how to set up an interview, how to conduct it, how to unfold the questions, what the scenario should look like. Should it be a quiet environment? Where should we conduct it? A lot of really great detail that I think we can learn from to make sure that we have really good interviews with our patients and we're not just doing them on the fly. So in this particular example, whoever did the BIMS, for whatever reason, they either didn't follow the instructions in the RAI, they didn't score it appropriately, maybe they didn't take into account all of the best interviewing techniques, what have you, and that patient scored a 13 to 15 on the BIMS. And you can see for speech language pathology CMI, that's 0.68, multiply it out, it's $15.06 per day. So again, we scored this person somewhere in the neighborhood of cognitively intact for whatever reason. But let's say in reality, that person had some sort of mild cognitive impairment. They had some issues with their short-term memory or what have you. And if we had scored this properly, we would bump up to a 1.46. So the previous example was $15 per day. In this example, it's $32.34. So again, just a score of 1 point on that BIMS, bringing them into an 8 to 12 versus a 13 to 15 is the difference of $15 per day for a speech language pathology CMI. So let's continue the same example. And again, these are very ideal, but it's just showing you how these components work. What if that patient also had some sort of dysphagia diagnosis that we didn't capture accurately on the MDS? Maybe it didn't come over in the medical records from the hospital. Maybe speech therapy didn't get in to evaluate the patient early enough. Maybe dietary didn't get their assessment in early enough. So if we only have that factor, that one factor in as a comorbid condition, so continuing this example, we went from a 1.46 now up to a 2.04 CMI. And the difference there is $32 up to $45. So again, that's a $13 difference, pretty significant. But then ask yourself the question, how likely is it that that patient would have a diagnosis of dysphagia without having an altered diet or some swallowing disorder? The chances of that are pretty slim. Probably not. Could it occur? Of course, but probably not. So if you add that in, again, you bump up to 2.85. So this is coding directly from Section K. Loss of liquids or solids from the mouth when eating or drinking, holding the food in their mouth or cheeks, residual food after meals, coughing or choking during meals, when swallowing medications. That's a really important one because I think, if you're in the dining room, I don't know who's overseeing your dining, but are they seeing that? Do they recognize that that's a factor that needs to be coded on the MDS? Are they communicating that to someone? I don't know. Does the person who's doing the MDS ever get to see that level of detail? Not really sure, but when we factor that in, we bump up to a 2.85. It's $63 per day, again, just by coding what's happening with this person, and that's an increase over that very initial example of $15 per day. So you can see how just very simple, and we didn't even change the diagnosis here. We didn't change anything. All we looked at was cognition and a swallowing disorder. So again, being able to capture those upon admission. So let me just pause before I go into nursing and talk just a speck about therapy delivery. So CMS has stated to us very directly that they feel individual therapy is generally best for the resident. That said, we know that we're going to see some group therapy, some concurrent therapy as we move into PDPM. And CMS is indicating that they're limiting that to 25% of the SNF's resident therapy minutes by discipline. So they're going to be tracking that through Section O. Obviously, Section O is going to be expanded and there will be total individual, total concurrent, total group, total co-treatment minutes that will be tracked there. They'll look at that. If it's over 25%, the facility will get a non-fatal warning edit on their MDS. So what we're hearing though, again, I love going to some of these CMS trainings because they talk a lot about this. CMS, John Kane actually said in one of the recent trainings, he said, I don't think we care how you deliver therapy necessarily. We're giving you options to use your best clinical judgment, providing that the outcomes are the same. But he also said, if you're not doing it now, if you suddenly start doing some of these things, it's going to be a bit of a red flag. So we want to make sure that, whatever we're doing, again, I don't have any strong opinions on what we do or don't do. I'm an OT by background and I'm very much trained in group process. But I think what we have to always keep in mind is what's clinically appropriate for the patient. We're already hearing in the provider community that, oh, we've been told we have to group people. I have run 2 groups a week and people are being grouped together that maybe don't belong together, somebody with a cognitive impairment and somebody else who's very high level. So the documentation still needs to show skill. It still needs to show the medical necessity. Again, Chapter 8 of the Medicare Benefit Policy Manual still applies. Still needs to be medically necessary and clinically appropriate for the patient. So that's what I would be looking for in the documentation is, if we're going to use some of these alternative models, that's fine, but let's just make sure that they are still clinically appropriate for the patient. Okay, so we're going to talk about NTA and nursing here just very briefly. Obviously, NTA, I think you already know, there's 2 categories, predictive of cost. Those are the resident comorbidities and the use of extensive services. And for each one of these, there is a score. And I'm not going to go through these in detail. You can certainly read these. But you can look at these. So for example, parenteral or IV feeding is taken directly from Section K. If you jump down and look at, for example, special treatment, a transfusion, that's taken from Section O. Wound infections, Section I. Other foot or skin problems, diabetic foot ulcers, Section M. So again, all of your MDS coding. Morbid obesity, there's your I-8000, again, a diagnosis codes. And again, you can see the others on this slide. So what I do want to say here, this is what's really important here is that you yourselves are scrubbing, we'll talk about the documentation from the hospital, but you yourselves are scrubbing that documentation that's coming from the hospital, the medical records, your current assessments of the patients, looking for all of these different things, because if the patient has them, we certainly want to make sure that we're coding them and coding them appropriately. If you're using a scrubber will look for maybe coding errors or some of those gaps, but it's not going to go through and identify and pull out the phrases in your documentation, pull out those ICD-10 codes. That's really going to be up to you and your team, your interdisciplinary team to go through those charts. And again, I don't know who that is. Maybe that's something that occurs at Medicare meeting or something else, but it's going to be critically important that we do look at that. So here's the NTA scoring. You can look at it ranging anywhere between 3.25 down to a 0.72 CMI, and you can see the score range anywhere between 0 and 12 plus. And again, CMS has said we're going to have pretty few people at the 12 plus range, but we'll probably have a number of folks at those lower 3 categories. Okay, so let's look at an example, again, of NTA. And in this particular case, the person comes in, and I'm just looking at this one variable. Person comes in and we code nothing. Maybe that's because we didn't get the medical records from the hospital. Maybe nobody went through them with detail. Maybe we just coded what was on, the face sheet from the hospital. So we see a case mix index of 0.72 and the per diem amount, you multiply that out. And now this one actually has that case mix index adjustment factor of 3 factored in here. So we see $168. So let's say, though, we go into that medical record and we find that the patient has an MDRO, a multi-drug resistant organism, VRE or MRSA or whatever they have, and they had that in the hospital, but we didn't catch it on the medical record. It was buried somewhere in there. That's 1 point. It's only 1 point, but look what it does. It bumps you from 0.72 up to 0.96, and for the first 3 days from $168 and change up to $224. Let's take it the next step. And let's say also the person has a diagnosis of COPD, an active diagnosis of asthma COPD or chronic lung disease, and they have shortness of breath when lying flat in the bed, all of those things. And again, if you didn't capture that from your medical records, you're going to miss out. That brings the NTA up now to 3 points and the CMI up to 1.34. And you can see the financial impact there. So initially we were what, 168, and now we're 313, almost $314. The other piece of that is, so capturing that, and we'll talk about this here now as we talk about nursing, but this person has a diagnosis of COPD, active COPD, head of the bed, yeah, can't be flat. That's also going to change the nursing category as well. That would pull them out of maybe a clinically complex, which is what we see here, into a special care high category. So again, capturing that information, I'm just showing you one component. It's going to filter across all of these different components. So let's talk about nursing for just a second. And I'm going to go through these slides kind of quickly and talk about just some high points. These are all of the different nursing case mix classifications, and a lot of them are the same as what we see now, the trach and vent, respiratory therapy, things like dialysis or radiation, surgical wounds, burns, those sorts of things. So a lot of these are exactly the same as what we're familiar with now. You'll see the fourth column over, there is a depressive end split. So that's really important as we get to these categories. The PHQ-9 is going to partially drive what the category is. And then there's also the restorative services, and there's your GG for function. And as I said earlier, I didn't put up that slide here, but that person can range anywhere between 0 and 16, a few of those categories that we looked at for PT and OT drop-off. So a couple things I want to say about nursing, and again, just things that we are hearing as we're going out and doing trainings and attending trainings. The first is about nursing documentation, and I didn't put any slides in here about that, but it's something we really need to look at. I don't know what you're seeing in your communities, but I can tell you what I see when I audit. I see A&O ×3, skin warm and dry, no complaints of pain. And some of you might be giggling that you see the same thing. Is that going to document skill? The answer is no. And again, we have to make sure that whatever we're coding, all of this is again driven by section I, your diagnosis code, and maybe section J, your surgery codes. Whatever we're coding as that primary diagnosis, we have to support in the documentation. What are we skilling that patient for? What types of things are we doing related to that documentation? And I'm going to show my age here. I remember years ago, we used to have cheat sheets on the chart. I don't know if any of you remember those, where we would say, this is what they're skilled for, this is what you need to document on, so that whoever was doing the documentation would know to put that in there, and again, really support what it was that we were skilling that patient for. So I think we need to go back to some type of format like that. I don't know what that would look like, but nursing doc is going to be key, because I think moving forward, again, what we're hearing from CMS is that denials are going to be component based. And if you don't have it supported, particularly by nursing, we could have a denial there that that we don't want to have happen. And I think historically, for the last however many years, denials have really rested on therapy because of medical necessity and the higher rugs. And with this new system, I think everybody's documentation needs to be spot on. The other thing, we're also hearing a lot about restorative. So I already mentioned earlier that folks are saying, well, I'm not going to deliver care. We're just going to let restorative do that. And to that, I would just say restorative is not the same as therapy. Obviously, there's a huge collaboration that occurs between the two disciplines, and it's a wonderful collaboration that I think can help prepare the patient for discharge. But the reality is they don't do exactly the same thing. And your patients are coming to you from the hospital, I think, for skilled care to eventually go home. And so if we're not providing skilled therapy care, I think that would play out in the marketplace. But I think on top of that, we're hearing over and over again that, oh, we need to bump up our restorative because our crosswalk, there's a crosswalk out there, maybe some of you have used it. Your crosswalk is showing you that all of your patients are falling into reduced physical function and some of those other categories. And we're thinking, okay, well, if I bump up my restorative, I'm going to be able to get additional reimbursement. Go all the way back to the very first slide, that I'm not sure that all of your patients really are going to fall into reduced physical function. If we look at the MDS and we're coding it accurately and capturing everything accurately, chances are pretty good that they're going to jump into some of those higher clinical categories versus the reduced physical function. So restorative is truly important, but I think if we're coding accurately, it's not going to impact reimbursement necessarily, because we're going to probably be in those higher categories. Okay, so let's look at an example here for nursing. So we have a 60-year-old female who was admitted into the hospital, complications of type 2 diabetes. She has encephalopathy, pneumonia. She requires oxygen. She was receiving, now she came into into the facility, this is important, on the 2nd of October. She was receiving IV feedings, IV meds, and oxygen during her hospitalization. And for the ARD, they chose day 8 as their ARD. The resident scored a 15 on the PHQ-9 when in reality, the resident suffered depression. What happened here, the resident was interviewed to determine the presence of a depression on a day that nursing was short-staffed and the person rushed through the PHQ-9, and it was conducted not in a private area, but in a loud, busy area. The resident has not been sleeping at night, had poor appetite, difficulty concentrating, and those were all scored as not present when in reality they were occurring daily. Oxygen is continuing to be administered as needed. And what this particular community did was they indicated that the primary medical condition was medically complex. So they were coding the pneumonia for this particular patient. And you can see the impact of that. So it gives us a clinically complex category for nursing, and you can see the impact there. Well, let's move forward and let's look at how we should have coded. Couple things here. I made mention that this person was admitted to the community on October 2nd. That's important because remember that we can look back into the hospital for some of these things like the parenteral or the IV feedings. And if we choose our ARD appropriately, we can capture that information from the hospital, and that would change the status for the patient. So the parenteral and IV feeding provides 7 NTA points, so we would be able to capture that. Now, in this case, they coded pneumonia as the primary diagnosis, but we also said that the patient has a diagnosis of diabetes with encephalopathy. So we code that instead. What it ultimately does is places this patient into a special care high category. What that would also do is that would place the patient into an acute neurological category for speech, so speech would be impacted versus medical management. It would also impact PT and OT, their diagnosis codes. Let's look at the PHQ-9. So nursing plans a time after the morning meds, the physician rounds, whatever. We do the interview in the resident's room while the roommate is somewhere away. We allow time to ensure that the resident understands the questions, and we get a PHQ-9 severity score of 6, just by conducting the interview in an appropriate way. So looking at the diagnosis code, looking at the NTA points, looking at the total severity score for the PHQ-9, it's a huge difference. So what we see here is the patient was initially at a $230, or excuse me, $138. We've now bumped up to $230, and really the biggest piece of that is just the diagnosis code. Other things that we didn't capture, we could have captured the active diabetes, which would also change the NTA category, add an additional 2 points. And again, you multiply that by 3. So again, it's all about capturing that data. So if you've not heard it 100 different times now, ICD-10 coding is a huge key to success for all of this. We can't continue to score UTIs for our patients or pneumonias for our patients. We really need to look at what are we providing skill for? Why is this person being admitted to the SNF? So CMS again has been very clear about that we can't just do what they did in the hospital. We have to look at why exactly we are providing services. The documentation then supports that, and that ICD-10 code will classify again the patient into a primary clinical category for PT, OT, speech, nursing as well, and then also impact those NTAs. So that's section I, and then this is section J. Again, capturing those surgeries. We check as many boxes as would apply, and a surgery means that the patient was an inpatient hospital for at least 1 day in the last 30 days, and that surgery carried some degree of risk to the patient's life. So again, where we can code those, that changes probably that PT and OT category into something that is surgical. So with that in mind, I think you're already hearing this. What is your MDS practice? If you look at what your practice is, A standard MDS should take anywhere between 75 and 90 minutes, and ANAC would back that up. And that might even be really low if you're really reading all of the hospital records. They say maybe 4.5 hours to do your comprehensive assessment. And if you think about the fact that we're not going to have all those OMRAs now, maybe we do have the time to do all of that. Going back to what does the RAI say? How are you selecting your ARD date? So that's why we use that example. If you can look back into the hospital, let's do that. I think, again, many communities are right now using day 8 to capture therapy minutes. We don't have to do that anymore. What we need to look at is what can we capture on that MDS that we are already providing to impact our reimbursement. Are you copying and pasting? Holy cow, I can't even believe I have to say that. But we are finding that some of the software programs for MDS allow you to copy and paste. And we've seen MDS coordinators just doing that time and time again versus truly assessing the patients. We've already talked about, section GG, and then, also looking at triple check, and we're not going to go into that in great detail, but looking at, is the therapy services documentation present? Do we have the physician orders? Is the MDS complete? Is it accurate? Is it submitted? Is it accepted? Did we meet Medicare compliance or clinical eligibility requirements? What's the diagnosis code? What did we put on the MDS? What did we put on the UB04? Do we have the certification, the signatures present? I mean, a lot of those different things we're going to need to continue to look at. So with that, if you wouldn't mind, Melanie, we're going to launch poll number 2 and then poll number 3 right afterward.
And here is our next poll. Please give your response. We'll share those results in just a moment, and then we will have another.
So the question is, how quickly do you receive hospital records from the transferring hospital? So are you getting those the day of admission, by day 3, within a week, or not at all?
Thank you, everyone. I'm going to go ahead and close this out and share the results.
Okay, so a lot of you are getting them day of admission, which is perfect. Oh, 3% of you are not getting them all. And we have some 3 days and within a week. So certainly something that we need to look at for timing. Melanie, if you wouldn't mind, go ahead and launch poll 3, and we'll look at that one pretty quickly, and then go back in to talk about how the MDS practices are impacted by this. So the question is, which hospital records are you receiving? Are you getting the H&P? Are you getting a discharge summary? And you can select all that apply. We get a big stack, but we have no idea what's in it. Hospital records? We get none. What are you talking about? So let's see what you're actually receiving.
All right, thank you for taking the poll. We're going to go ahead and close that out. And here are the responses.
Okay, so most of you are getting the H&P. The majority of you, over half of you, are getting the hospital discharge summary, and there's still that group that we're getting a stack and we're not necessarily sure what's in it. So we'll talk about that in just a second here. So Melanie, if you don't mind going back to the slides, that would be great. And we're going to talk about this as it relates to the MDS. So again, this is really important. You need to get that information from the hospital. We know that the ARD for the 5-day needs to be set by day 8, and we want to pull as much of that information in as possible to code it. And if you're getting those within a week of admission, that's too late. You're not going to get that on your 5-day. And remember, the 5 days should determine payment for the entire stay. If you're getting it by day 3, that might be okay if you have the time, again, to weed through it and weed through it quickly, again, considering that you may look back into the hospital for your ARD. So this is one of those things where you really need to figure out how we're going to weed through all of those things. And that might be something you do for quality assurance, just checking, are we getting the documentation? Is it skilled? Are we coding it? Who's going through it? Are we capturing everything? That might be a really good quality assurance performance improvement plan. So let's look at a couple of, I will tell you, these are real examples from facilities, and I'm going to try and give you the background pretty quickly and show you then the impact. So we have a situation here, 93-year-old male, came in, mental status changed, diagnosed with acute encephalopathy, acute kidney failure, pneumonia, and a UTI. He was in the hospital for 5 days. He came into the community with lack of coordination, weakness, hypertension, legal blindness, a diagnosis of depression, dementia, glaucoma. He was seen by wound care. He has a few skin areas of concern. He has a stage 3 on his right buttocks and on his sacrum, and some on his left heel. He had a nutrition assessment, and he had a 6.5-pound weight loss in the last 30 days. Dietary recommendations were made. He had a diagnosis of failure to thrive. With a diagnosis of dysphagia, speech assessed to determine the most appropriate and most efficient diet consistency. He was seen not to be able to chew solid food items, and he was holding food in his mouth after the swallow. They altered his diet, and the medical record identified an admission diagnosis of a UTI. Section GG shows that he is dependent in all areas, and his BIMS score was a 2, PHQ-9 was a 0. So you can see the impact here. This point places the patient into a medical management category because they coded the UTI. That's for PT and OT. Medically complex for nursing. The BIMS score, you can see what that does to speech. We know that the patient had a swallowing disorder and a mechanically altered diet. They coded no NTAs. This patient is in a special care low for nursing, specifically because of those stage 3 pressure ulcers. And again, you can see the impact. The average per patient day here is 548.81. So I put some very specific things in there. And again, this is a real example from a case that we've been auditing. What if instead we diagnosed this patient, we indicated in section I, the acute encephalopathy, because that's truly what we are addressing, that mental status change. That bumps that patient up to an other neurologic category, and it bumps them from a special care, it keeps them actually in a special care low, but it changes significantly the PT, the OT, and the speech categories. We know that this patient now has a dysphagia diagnosis. We didn't code that previously. Under NTA, we can code the malnutrition, and we can code the adult failure to thrive. Again, that's getting that information from your dietary consult and or your hospital records, and you can see the impact here. So we went from 548 per day up to 618. We didn't deliver any different care. We just coded what was going on with the patient. Another example, we have an adult female, 80 years of age, admitted to the hospital, history of hypertension, COPD, diabetes, protein malnutrition. She had a fever, most likely due to a UTI and sepsis. She also has a diagnosis of metabolic encephalopathy due to the sepsis, C. diff, and colitis. She's on 2 liters of oxygen. Her head of bed is elevated for breathing. Her functional scores, I'm not going to go through them in great detail. She was mostly dependent. She was seen for speech for dysphagia. She had, again, difficulty chewing. She had a delayed swallow reflex, and she scored a 3 on her BIMS. So again, you can already start thinking, you know, they coded the UTI, and look what happened. That medical management acute infection placed the patient into a medically complex condition and a nursing category of clinically complex because of the diagnosis of pneumonia. Under the NTAs, they did code the diabetes, the colitis, the C. diff, and the MDRO, obviously for the C. diff, and the mechanically altered diet for speech. So you can see the average per day is 592. But again, if we would have coded that encephalopathy, which is very common, that would place that person into an other neurological category. This particular community failed to code the CVA, the history of CVA, a history of dysphagia or the current dysphagia, the swallowing disorder, the respiratory failure, the COPD, the malnutrition, the COPD with the shortness of breath lying flat, the stage 3 sepsis. All of those things, again, places this patient into an other neurological condition and then special care high for nursing. So it's a bump up from 592 up to 744. Okay, final example, and then we're going to go through Medicare meeting just super fast. This one, we have a 77-year-old female at the hospital. She was found lying in the grass, found to have a lower extremity DVT, MS, diabetes, dementia, depression. She's at the SNF now. She is confused, disoriented, requires redirection, physical assistance with pretty much everything. She's verbally aggressive. They've encouraged her to attend events, but she prefers to stay in her room. So obviously there's a PHQ-9 impact there. So in this case, they diagnosed her with debility, and you can see that that places her into a clinically complex category for nursing. The PHQ-9 was scored as a 0, GG was scored as a 16. The BIMS was scored as a 15, and I tell you again, this is a very real example, but the patient had a diagnosis of dementia. Again, we didn't code what we were supposed to code. We probably should have coded instead an acute neurological diagnosis. She has a diagnosis of MS, which will impact PT, OT, speech, and nursing. The GG score is not 16, it's probably 9, and that impacted PT, OT, and nursing as well. The BIMS, we know that she's not a 15, she's actually a 10, and that changed the speech CMI pretty significantly. Under the NTAs, we missed the multiple sclerosis. And again, the change in the GG score actually places this patient into a totally different category, puts them into a special care low, and the end split for depression is captured, so it changes it significantly. Again, the difference here, 480 per day up to 623. So with that, again, significant impact just by doing what you're coding. So Melanie, I'm going to ask, do you mind opening poll number 4, and let's give them just a little bit less time this time to go through this so that we can get through this last section.
Absolutely.
If you don't mind. Thank you. So the question is, have you begun to retool your Medicare and your stand-up meeting to meet the needs of PDPM? So the question is, answers are yes, we're well on our way. No, we still have some work to do. Wait, you mean we need to change how we do things? So if you wouldn't mind answering that one, and then we'll talk about Medicare meeting here in just a second.
Great, thank you everyone. We're going to go ahead and close this out. There we go.
Okay, so 32% of you are on your way. I love the people, 5% who said, wait, we have to change something? And 63% of you have some work to do. So thank you for sharing that. If we don't mind going back into the slides, let's talk about Medicare meeting. And this again goes back to those hospital records. The first question you need to ask, did we get all of this information, the H&P, the discharge summary, the surgical report? And this is really the place where you as an IDT determine that primary reason for admission, the primary diagnosis that you are going to score, you're going to code in I-0200 of your MDS. Additionally, in your Medicare meeting, there's a lot that needs to be done here. Did you do the skilled nursing assessment? What about the BIMS? What about the PHQ-9? Who did it? Is it accurate? Did therapy score something? Did nursing score something? Let's look at the scores and let's try and figure out which one accurately reflects who the patient is. Do we do our vital signs? Do we have documentation present? Again, if you're going to code it on the MDS, it has to be in the documentation. If it's in the documentation, we want to capture that on the MDS. So this is a great quality assurance type of process. And I'm not going to read all of these at you, but these are all of those things that are going to impact your NTAs, are going to impact all of your CMI. So your therapy evaluations, your dietary documentation, bowel and bladder, restorative, respiratory, and the list goes on and on. We can look also when we're at Medicare meeting, is the resident receiving any of these treatments, enteral feedings, oxygen, IVs, et cetera? Did they receive any of those in the hospital? How does that impact the ARD that we choose? How does that impact what we're coding on the MDS? And again, what we might possibly capture. I think too, Medicare meeting it has to change. We need to talk about, has the resident's condition changed? Do they have a new diagnosis? Is anything else going on? Because that's obviously driving your interim payment assessment. So this is where we start talking about that piece of it. We talk about documentation. You know, does nursing documentation contradict therapy and vice versa? Because this is, again, where we might see denials when those don't match up. I think those last 3 things are really important: the functional status, the discharge plan, and the barriers. I think today in Medicare meeting, we go in and we say, okay, patient's walking 50 feet with min assist, dressing with min assist, going home next Thursday. And that's Medicare meeting. Medicare meeting now needs to be, okay, we're going home, where do we need to be? What are our continued barriers? What do we need to do for a successful discharge? What we're not talking about here, which I think is important, is you are still overlaid with, quality reporting and 5-star and other things that are looking at your successful discharge to the community. So again, knowing that, that drop from day 20 to day 21 is not a huge impact in dollars, we need to make sure that we are keeping this patient as long as is necessary to make sure that we have a successful discharge. Obviously, we don't keep them if it's not clinically indicated. That doesn't make sense, but we have to prepare for discharge. So figure out what that discharge scenario is and what our barriers are. So final slide, our outlook, what is it? Be proactive, start preparing yesterday. Definitely build those relationships with the hospitals. I can't stress enough, and I'm sure you heard it, how important those medical records are. Triple check, quality assurance, Medicare meeting, all of those things are going to be important, and especially focusing on the correct coding. I think you saw through some of the examples just how much that's going to drive PDPM. So with that, I want to say thank you, and I will turn it back over to Melanie.
Great, thank you, Dr. Weissberg, for the excellent presentation. If you have any follow-up questions, you can type them into that question box now, or you can please email me directly at mmotiska@fhca.org. Certainly anything that occurs to you later, we'd be very happy to field it and pass it along to Dr. Weissberg. We will follow up with a Q&A document, and we'll make it available to the attendees on the website with that recording of the webinar. Again, a big thank you to our presenter, Dr. Kathleen Weissberg of Select Rehabilitation. And finally, a big thank you to our supporting sponsor, MedPass. And as always, we thank you for attending today's webinar and for your work to provide person-centered care in Florida. This concludes our webinar. Have a great day, everyone.